Welcome to our webinar, What's the Link Between Myopia and Glaucoma? My name is Michelle de Elizalde, and I am the Assistant Director of Patient and Research Programs at Glaucoma Research Foundation. Joining us today is Dr. Sarvat Salim. Dr. Salim is a renowned glaucoma specialist and professor at Tufts University of Medicine. She serves as the Director of Glaucoma Services at St. Elizabeth's Community Practice and as Vice Chair for Clinical and Academic Affairs for the Department of Ophthalmology. Dr. Salim completed her medical degree and ophthalmic residency at the State University of New York and her glaucoma fellowship at Yale University School of Medicine. Dr. Salim served on the board of AAO, the American Academy of Ophthalmology, and on their very important myopia task force. Her expertise lies in diagnosing, managing, and surgically treating glaucoma. Please welcome Dr. Sarvat Salim.
Good afternoon, everyone. Thank you so much, Michelle, for your very kind introduction and for the invitation to discuss this important topic. Before I start, I would like to take this opportunity to acknowledge Glaucoma Research Foundation for being such a great leader in the glaucoma community. I want to thank the foundation for providing educational materials and organizing these programs and webinars that are so important to our patients. I also want to thank all the attendees. From what I understand, we have over 900 registrants for this program, and I hope you will find this program to be informative. I have no financial interest in this topic. I understand we probably have a mixed audience here, and I would like to give a very brief overview of glaucoma to those who may be joining one of these programs for the first time. Glaucoma is one of the leading causes of vision loss. Approximately 80 million people worldwide have glaucoma, and 3 million Americans are now suffering with glaucoma. Glaucoma affects all races and ethnic groups. It is the leading cause of blindness in African Americans, and African Americans are 6 to 8 times more likely to get glaucoma than whites. Hispanic Americans carry an intermediate risk between the white and Black persons. So what exactly is glaucoma? It is a disease of the optic nerve. The optic nerve is a part of our central nervous system. It conducts signals and relays visual information from the eye to the brain to form an image. Damage to the optic nerve takes place in glaucoma related to high intraocular pressure. Most forms of glaucoma have no warning signs, and vision loss usually occurs at the side or periphery. And that's the challenge we have, because patients sometimes don't know they are suffering with this disease. And by the time they find out they have vision loss, a lot of damage has already occurred. Our treatment strategies for glaucoma are directed at lowering intraocular pressure by medications, laser, and surgery. There are many different types of glaucomas. Primary open-angle glaucoma is the most common type of glaucoma in the United States. And as I mentioned before, the main risk factor is elevated intraocular pressure. This is also the only modifiable risk factor. Other risk factors include advancing age, family history, African ancestry, myopia, which is a topic of discussion today, and also some systemic diseases such as diabetes and hypertension that can also increase one's risk of developing glaucoma. The examination and follow-up of glaucoma requires many different tests. Tonometry is the technique to measure intraocular pressure. With pachymetry, we measure the thickness or thinness of the cornea, which is the outer layer of the eye. And this is important because it can affect our IOP measurements. Gonioscopy helps us to differentiate if someone has open-angle glaucoma or closed-angle glaucoma. Ophthalmoscopy is the clinical evaluation of the optic nerve. We have many imaging devices, and they assist us for early detection of glaucoma. Perimeters and visual field analyzers help us to determine the extent of vision loss in these eyes. This is a fundus photo of a normal retina and normal optic nerve. Let me go over this with you briefly so you understand the pathogenesis here as to what happens with glaucoma. The optic nerve is a bundle of nerve fibers and looks like a round structure. Inside the optic nerve is this pale depression, which is called the cup. The tissue between the edge of the optic nerve and the cup, this healthy pink tissue, is known as the neural retinal rim or rim tissue or healthy nerve tissue. What happens in glaucoma is that the pressure gets high and it affects the optic nerve. The size of the optic nerve does not change, but the cup size increases in response to high pressure. And as you can see, when the cup will increase, the rim tissue actually decreases. And this loss is irreversible, and then it leads to vision loss. These are some glaucomatous optic nerves. And I just want to show you here, for example, you can see this very enlarged cup size here. Also, this thinning of this rim tissue superiorly. Here also a large cup size. The rim tissue is thin here superiorly and temporally. In this picture, you can see a very large cup size, and there's a significant thinning of this rim tissue temporally. Sometimes we can see these hemorrhages, and they are an indication to us that we need to be more aggressive in our treatment of glaucoma. This is someone who has very advanced glaucoma, and you can see almost the entire optic nerve is cupped and there's no healthy tissue. Same thing with this optic nerve, very advanced cupping. One of the things that I want to point out to you is this degenerative changes outside of the optic nerve. This is known as peripapillary atrophy, and this is thinning of the chorioretinal tissue around the optic nerve. This peripapillary atrophy is nonspecific, and it can occur in glaucoma. It can also occur in myopia. And this makes our assessment of the optic nerve very difficult when patients have coexisting myopia and glaucoma. Also, this peripapillary atrophy affects our ancillary testing, which I will discuss later. Once this neural tissue or nerve tissue is lost in response to increased cup size from high pressure, people can lose vision. So on the left side of the screen is a normal visual field. This patient has no vision loss. And with early glaucoma, one starts to have this very peripheral loss. And with time, if the IOP is not controlled, this can advance. And here in this patient, there is inferior loss taking place. And with time, this loss can get more dense and darker. Here is someone who has significant loss inferiorly and superiorly. And the only place patient can see is from this little circle in the center. So this is an example of a very constricted visual field where patient is basically seeing through a tunnel. And on the extreme right is someone who unfortunately has lost all vision. So now let's discuss what is myopia. How do we define myopia? So in emmetropia, there's no need for glasses. The incoming rays of light are focused at the back curtain of the eye, the retina, and it forms a very sharp and clear image. In myopia, which is also known as nearsightedness, the length of the eye is longer. And these rays of light, when they form an image, they're not forming on the retina, they're actually forming in front of the retina. So patients do not see distance vision clearly. They can see near clearly, but they have issues with their distance vision. And myopia is corrected with the use of minus lenses or concave lenses, which then tend to diverge these rays, and the image is again formed on the retina. Eye growth is regulated by visual input. Light intensity and image clarity are critical for eye growth. Signals to peripheral retina cells control posterior eye growth. And eye growth increases if these cells receive a blurred image. And what happens in response to blurred image, the posterior wall of the eye gets thinner, eye gets longer, and then eyes become even more nearsighted. So why are we concerned about myopia? Why are we talking about this topic of myopia and glaucoma? Well, myopia is becoming a very serious public health challenge. In 2010, nearly 28% of the world's population was affected by myopia, and the projection for 2050 is 50%. So 1 out of 2 individuals will have myopia. The myopia prevalence, as I mentioned earlier, affects all races and ethnic groups, but there are some groups where there's a very dramatic increase, such as East Asian population. On this graph, we're basically showing you estimated myopia prevalence at 15 years. So as you can see here, in some East Asian countries, these teenagers, many teenagers have myopia, and it's about like 70 to 80% of the population of teenagers. Now, myopia can have different levels. Someone can have low myopia, moderate myopia, or high myopia. High myopia is defined as having a refractive error more than at least -6 diopters. And what we're seeing here is the prevalence of high myopia that's also increasing with time. So we are somewhere here in 2023. And here is the number of individuals in millions who have high myopia. So currently about 300 million individuals have high myopia. But by 2050, this is going to triple to almost 925 million individuals. High myopia, which can also lead to pathological myopia, increases risk for many other eye diseases. And today we're discussing glaucoma, but high myopia can also result in increased incidence of cataracts, retinal detachment, and myopic macular degeneration. This graph shows global blindness and visual impairment associated with myopic macular degeneration. The gray bars here indicate blindness, and the white bars are indicating visual impairment. Once again, we're somewhere here in 2023, and you can see in the next 25 to 30 years, the incidence will increase significantly for both blindness and visual impairment. So as you can see, myopia epidemic will have significant impact not only on clinical care, but also education, advocacy, research, and economy. Actually, there was one study done which showed that the global economic productivity loss for myopia was reported to be about $300 billion international dollars for uncorrected myopia. This is a slide from a presentation that was given by our past CEO of the American Academy of Ophthalmology, Dr. David Park. He outlined some major strategic initiatives for the board. And as you can see here, bullet number 4, he discussed myopia being the biggest public health challenge of our time. Soon we understood the importance of this epidemic, and the Academy convened a task force on myopia. Individuals and experts on myopia were invited from many different parts of the world. And as you can see here, we have representation from Singapore, Germany, Australia, Poland, Ecuador. I had the pleasure to serve on this task force as well. The major objective of this task force was to develop an evidence-based white paper that provided rationale for prevention and early intervention for myopia, reviewed available approaches to control myopia progression, and outlined next steps to address this public health challenge. Now, this is something I want to emphasize, and this is something we also emphasize in this white paper that was developed by the Myopia Task Force. Yes, myopia is becoming an epidemic, and it will lead to increased incidence of many other ocular diseases, including glaucoma, but we need to control this epidemic in childhood. And this is a very important graph on your left side that I want to share with you. Here, what we are seeing, no matter what background you're coming from, Asia, Europe, or mixed group, you can see here from this graph that myopic shift occurs when kids start school, and the average progression of myopia is about half a diopter per year. 50% are stable by age 15. For those who develop high myopia, which again is defined as nearsightedness more than -5 or -6 diopters. And these are the individuals who then go on and develop these other ocular diseases in their later adulthood or when they become more senior. So we really have to address and control myopia in childhood. Our paper also discussed current approaches to controlling myopia. What can we do at this time to control myopia? Luckily, we have a few different avenues. We can use behavioral approaches, optical approaches, and pharmacological options as well. In terms of behavioral approaches, just like childhood obesity, we have to get our children outside. We have to increase outdoor exposure. And why is that important? Many studies have shown that light exposure slows myopia onset. The work is still ongoing in terms of how much time is needed, but at least 1 hour has shown to be effective. And of course, if more time is spent outdoors, it will be more beneficial. And why is it that sunlight or outdoor exposure is helping us? It has to do with release of some neurotransmitters in the eye, which tend to remodel the connective tissue in the eye and inhibit the axial length elongation in these myopic eyes. The other behavioral approach is to minimize near work. During COVID, many children were spending even more time with their mobile devices, and we saw an increased incidence of myopia during COVID pandemic as well. So we have to minimize near work, and the American Academy of Ophthalmology has proposed a 20-20-20 rule. What that means is that when a child is using a mobile device for 20 minutes, have them take a break, look 20 feet away for 20 seconds. Also, the reading distance should be kept at more than 8 inches. So those are some behavioral approaches. There's a lot of research being done in terms of optical approaches, looking at different types of spectacles and contact lenses. In terms of pharmacological intervention, the main drug that is being used for myopia control is atropine. It is an anti-muscarinic agent, and many studies and clinical trials have determined its efficacy. The data is very compelling, but most of the data actually is coming from Asian countries. Currently, atropine is used in low dose to prevent any side effects, and we have to target, again, the younger children. Clearly, more research needs to be done in this area. As I mentioned, most of the data is coming from different countries, and we have to see how this medication is going to help our children in terms of the concentration, in terms of the age of initiation of drops, and for how long do we continue these drops to prevent rebound. So now I want to move on to myopia and glaucoma. As you heard, I am a glaucoma specialist. I see these patients all the time, and patients who come with coexisting myopia and glaucoma present numerous challenges to us. Many population-based studies have reported a 2 to 4-fold increased prevalence of glaucoma among myopic subjects. And this association is stronger for those who have moderate to high myopia. So once again, as the severity of myopia increases, the risk for glaucoma also increases. Why are these myopic eyes more at risk for glaucoma? As I mentioned, myopic eyes are long eyes, and there are structural abnormalities of collagen fibers. And as a result, there's thinning, stretching, and weakening of different types of connective tissues in the eye. And these alternations make optic nerves extremely susceptible to glaucomatous damage at any level of intraocular pressure. And of course, the risk is higher if the pressure is higher. This is an important study that came out of Singapore that I want to share with you. Here, the colleagues, Tam and other authors, they investigated myopia in terms of diopters and intraocular pressure as risk factors for glaucoma. So if you look at here on the y-axis, here is intraocular pressure status, eyes with less than 20 millimeters of mercury pressure and eyes with more than 20 millimeters mercury of pressure. And on the x-axis, we are seeing different levels of myopia, non-myope, low myope, and high myope. So if there's an individual who is a non-myope and has a pressure less than 20 millimeters of mercury, the odds ratio of developing glaucoma is 1. In contrast, if a patient has high myopia and has pressure more than 20, this patient is 4 times more likely to develop glaucoma. This slide is showing something else. This slide is now looking at the axial length, or the length of the eye, and IOP as risk factors for glaucoma. Once again, on the y-axis, we have the IOP measurements, and then on the x-axis, we're looking at different axial length of the eye. So most eyes have axial length about 23.5, that's like average. So compared to someone who has an average axial length and pressure less than 20, if we have an individual who has myopia, who has a long eye, say more than 25.5 millimeters of mercury, and has a pressure greater than 20, this individual is 16 times more likely to develop glaucoma. So this is really important information that came out, because not only we have to pay attention to the diopter of myopia, but we should also be measuring the axial length for these individuals as we're looking at other clinical tests. So when patients come with myopia and glaucoma, we have many diagnostic challenges, not only in terms of just clinical assessment of the optic nerve, but we also have some limitations of our ancillary tests, both structural tests and functional tests. And let me share some of these findings with you. So in terms of clinical assessment for glaucoma in myopic eyes, it's very difficult. Myopic optic nerves can be quite challenging to interpret. Myopic nerves can be small, they can be very large, they can be tilted, as shown here, and often they have this very large peripapillary atrophy that I discussed with you earlier. So all these changes make it very difficult to assess the size of the cup, the health of that nerve tissue or the rim tissue between the cup and the edge of the optic nerve. And these very large peripapillary atrophic areas also interfere with our ancillary testing and confound our findings. So this is a printout of optical coherence tomography. This is an imaging device that we use for glaucoma patients. This test helps us to measure retinal nerve fiber layer, which is the tissue around the optic nerve. We know that in glaucoma, there's thinning of the retinal nerve fiber layer. And there are also many challenges when it comes to myopic eyes, because thinning of the retinal nerve fiber layer can also occur in myopic eyes. Myopic eyes are also not well represented in the reference database. So anytime we do these testing on glaucoma patients, they're compared to age-matched control. But many of these myopic eyes are not in that database, so it's very difficult to make head-to-head comparison. Also, many myopic eyes have an atypical distribution of retinal nerve fiber layer, and that can affect our assessment as well. So let me now draw your attention to this printout. I know it looks very complicated, but I will try to make it simple for you. Just take a look here. This round structure, again, is the optic nerve. This side is the right eye. So this is the information for the right optic nerve, and here's the information for the left optic nerve. We're looking at the retinal nerve fiber layer around the optic nerve. And as you can see from this color here, the red and yellow, that is showing a very healthy, very robust retinal nerve fiber layer in both eyes. And if you look here in the left eye, everything is green. Green means everything is normal. Yellow is borderline, and red is abnormal. Now, if you look here in the right eye, it's showing us that there's some thinning happening in the superior part of the optic nerve. And is this glaucoma? Is this myopia? How do we know? But I want to draw your attention here. Myopic eyes, as I mentioned before, they tend to have an atypical distribution of the retinal nerve fiber layer. And here what we're seeing is this temporal shift that we normally see with myopic eyes. So with this temporal shift of this peak, you can see that the shift is, as this peak is shifted temporally, there is this superior thinning. So this is actually due to myopia and not necessarily glaucoma. And let me show you this further. So this is the same picture that I showed you in the previous slide, but here I want to give you more information on this particular patient. We're looking at the optic nerve, and you can see this is the right optic nerve, which is large, but the left one is even larger. And the cup is here very large with temporal thinning of that nerve tissue. We do have this large peripapillary atrophy. Same thing here. But if you look at our visual field printout, luckily this patient does not have any vision loss. So yes, optic nerves are looking suspicious for glaucoma, but this patient has myopia. Visual field is normal, meaning there's no vision loss, and we think this little change here is due to this temporal shift from myopia. So we felt that this patient has just myopia, and although there is suspicion for glaucoma and we will continue to monitor, the decision was made not to treat this patient and just monitor. Here is a different patient who came with coexisting myopia and suspicion for glaucoma. Once again, take a look at this large optic nerve, take a look at the large optic cup. The cup is also deeper. We also see this peripapillary atrophy here. This is the right eye. If we look at the left eye, the nerve is larger, the cup is larger, the cup is deeper. Again, we have this peripapillary atrophy. If we look at our imaging modality, and here's a different test, this is called HRT, you can see that in the right eye, we're seeing more green, which is good, but in the left, we're seeing diffuse thinning, all this red stuff. And if you look at the visual field, the patient missed some spots in the right eye, more spots in the left eye. Now, this particular patient had a very strong family history of glaucoma. The patient's intraocular pressure was very high, and pachymetry measurements revealed very thin cornea. So the decision was made to treat this patient. Myopia and glaucoma are challenging, and in many of these patients, we really have to look at all different pieces of the puzzle, and every patient has to be analyzed individually to make a decision if treatment is warranted or not. Moving on to visual field defects. Of course, I told you that when glaucoma kicks in, when we lose that nerve tissue, people lose vision, and it's an irreversible loss of vision. But we can have visual field defects in myopic eyes, irrespective of glaucoma. There was a study done by Kumar and colleagues, and this was very interesting because in this study, they just looked at myopic eyes without glaucoma. And guess what? 80% of these individuals had visual field defects. That's a quite high percentage. And the distribution or the characteristic of these visual field defects were very similar to what we see in glaucoma. And then there was another study conducted by Doshi and colleagues. Here they evaluated 16 myopic Chinese men. Some of them were diagnosed with glaucoma, some were being followed as glaucoma suspects. All of these patients had baseline visual field done. And after 7 years of follow-up, none of these patients had optic nerve visual field progression, irrespective of IOP lowering. So that is quite interesting because what this tells us as clinicians and surgeons is that eyes which have glaucoma and myopia are difficult. And number two, myopic eyes can be sometimes undertreated or overtreated for glaucoma. Here is a patient who has been followed for 17 years on the glaucoma service. And this is his baseline visual field, myopic patient. And if you look, the nerve looks very concerning, large cup, a very thin rim, this large peripapillary atrophy. And then 17 years later, we got another fundus photo, not the best quality photo here, but pretty much it looked the same. So then what do? Just continue to observe? Well, I went and I looked at all his visual fields to see what has been going on in these past 17 years. So this was his baseline visual field in 1999, and you can see there's inferior loss of vision. 5 years later, in 2004, it looked pretty similar. Then in 2009, we see the inferior defect, but we also begin to see something happening superiorly, especially right here in the central part of the visual field, which is concerning because that involves your central vision. In 2013, it actually looked better. And then in 2015, we're pretty much back to where we were in terms of baseline. So this is just showing you longitudinal follow-up, and that's something very important in these patients. This patient, if we had not looked at all these visual fields over a course of years, this patient could have been treated for glaucoma, which was not necessary because these defects for this particular patient are due to myopia. So in summary, myopia is becoming a significant public health problem. There is strong epidemiological evidence that links myopia and glaucoma. As I have shared with you, myopic eyes show many structural and functional defects that are difficult to distinguish from those caused by glaucoma, and therefore long-term follow-up, longitudinal follow-up is critical for these patients. Currently, the American Academy of Ophthalmology and many other national and international organizations are working together on educational resources, advocacy efforts, and research to address this global epidemic. So what can you do? It is very important for you to inform your doctor if there is a family history of glaucoma, myopia, or blindness. You need to know your severity of myopia. Do you have low myopia, moderate myopia, or high myopia? Keep other risk factors in mind that I shared with you: high pressure, family history of glaucoma, advancing age, African ancestry. Definitely get a comprehensive eye exam if you have any of these risk factors, and also get all glaucoma tests to establish a baseline for yourself. Your doctors have all these copies in their electronic medical records, but you should also keep copies because the doctor may move or you may move to a different location, and you need to have this information for future follow-ups. And I encourage all of you to please get yourself monitored regularly. And with that, I think this is my last slide. So thank you so much for your attention. And once again, thank you to Michelle and Glaucoma Research Foundation for giving me the opportunity to discuss this important topic with you today.
Thank you, Sarvat. That was amazing. I learned so much about myopia that I didn't know about. So this is always helpful. We got lots of questions. One of them, which I found very interesting, because at the beginning you were talking a lot about myopia increasing in the population in the future and how we're going to be, and by the year 2050, we're going to be tripling the amounts. And why will there be more people with myopia in the future?
Well, as I mentioned, there are two reasons. One is genetic predisposition in some individuals. So if one parent or both parents have myopia, you're more likely to develop myopia. Number two, environmental factors. And that's why I stressed on getting our kids outside and get them to have more exposure of sunlight. We're living in a very digital arena. Our world is getting more digital. Our children are spending more time on these mobile devices. And increased near work is also associated with increased incidence of glaucoma. So I think they're both environmental and genetic factors.
Thank you. And moving on to a little bit of an association with glaucoma, how does myopia affect treatment options? Does it add risk to standard glaucoma surgeries?
Oh, wonderful question. Thank you for the person who asked this. So as I mentioned, all our treatment modalities are directed at lowering intraocular pressure. We start with our conservative management first. We usually start with eye drops, and they work by different mechanisms. They lower intraocular pressure by either decreasing the production of fluid in the eye or increasing the egress of fluid out of the eye. If medications don't work, we can do laser. Although many patients are now opting for laser as the initial intervention. We have many clinical trials which are coming out showing laser to be as effective as medical therapy for first intervention. And if medications don't work and laser does not work, then we have option of surgery. This is a very exciting time for surgery in glaucoma. We have many different options. the procedure that we choose depends on the severity of glaucoma. So there's something called microinvasive glaucoma surgery, which has gained a lot of momentum in the last, I would say, 10 years. These procedures, because as the name implies, microinvasive glaucoma surgery, they are safer, but sometimes they don't bring the pressure down to the target that we're looking at. So these procedures may be good for someone who has early to moderate glaucoma, but may not be the best option for someone who has advanced glaucoma. When someone has advanced glaucoma, we're trying to get to IOP or pressure as low as possible. And that is usually accomplished with our incisional traditional surgeries. And our two common incisional surgeries are trabeculectomy and glaucoma drainage devices. And I'm giving a very long answer for your question, but it's important because what I'm coming to is that when someone has advanced glaucoma and someone needs trabeculectomy, which is the traditional surgery, it carries a high risk of complication in myopic eyes because myopic eyes, as I mentioned to you, are longer. The tissue is thin. So when we do trabeculectomy, we basically are creating an opening in the sclera, the white part of the eye under the eyelid. And because the tissue is thin and stretched, these eyes can go from one extreme to the other. They are very high risk of developing hypotony, which is low pressure. And that's very difficult to reverse because low pressure or hypotony can also cause changes in the macula and it can affect vision. So we have to be very careful with our approach when we're doing trabeculectomy. We have to modify our surgical approach in these myopic eyes to minimize side effects and optimize our outcomes.
Thank you. That clarified a lot. But I just, when you were talking about laser surgery at the beginning, just to make sure, you were talking about SLT, not about LASIK surgery. Okay, because we did get, sorry, go ahead.
Yes, I was talking about selective laser trabeculoplasty.
Yes, because we did get a few questions about LASIK surgery and if you can have LASIK surgery when you have glaucoma.
So that's a bit controversial. I have written on this topic, and for many years, I have given education programs at the annual meeting of the American Academy of Ophthalmology to raise awareness about candidates who have myopia or may have eyes that are looking suspicious for glaucoma and are thinking about getting refractive surgery. I don't think refractive surgery is a contraindication, but there are some preoperative, intraoperative, and postoperative considerations. The refractive surgeons have to be aware of those considerations. The glaucoma specialists have to be aware of those considerations. And our patients also need to be more knowledgeable. So what I would recommend to whoever asked this question and others who may be interested in this topic is make sure you empower yourselves with the knowledge. Make sure you get a baseline examination. Make sure you get evaluated by a glaucoma specialist. Because if you're just a glaucoma suspect or you have early glaucoma, you may be okay for the procedure, meaning LASIK or refractive surgery. But if you have advanced glaucoma, you may not be a suitable candidate. So baseline testing, baseline evaluation is very important. There are many different types of refractive surgeries. LASIK is the most commonly performed procedure, but there's also PRK. Now there are new versions such as SMILE, and some of them may be a bit more gentle on these eyes than other.
Thank you. Another question that came in is, as we age, people become more farsighted. Does this reverse some of the structural effects of myopia with age?
No, unfortunately, all these changes are permanent.
Can I tell whether I have high myopia by looking at the prescription written by my doctor?
Yes, you can. So it's also a bit tricky because many different studies define the extent of myopia differently. But in general, I would say between 0 to -3 diopters of myopia is considered low myopia. -3 diopter to -6 is considered moderate myopia. And anything that's worse than -6 diopters is considered high myopia. So when you see your prescription, look at the minus number, and then this way you will know which category you belong to, low, moderate, or high.
Thank you. That's good to know. I have another question about different types of glaucoma. So does myopia affect different types of glaucoma differently, specifically normal tension and exfoliative glaucoma?
So very interesting and very important question too. Myopia, as I mentioned to you earlier, is very big issue in East Asia. And there are many different types of glaucomas. So my discussion was mostly based on primary open-angle glaucoma and myopia interaction. But many patients, for example, in Japan, have something called low tension glaucoma or normal pressure glaucoma. What that means is that the pressure is always measured in the normal range, but that pressure is high for that particular individual. And even though it's reading normal, it is causing glaucomatous damage in those eyes. So that's normal pressure glaucoma. And we're seeing a very high incidence and prevalence of normal tension glaucoma in Japan. And myopia is also very prevalent there. So again, there are some genetic predisposition to both of these conditions, and environmental factors may also play a role. One thing that I want to say, whether we're dealing with high pressure glaucoma or low pressure glaucoma, our treatment again is directed at reducing intraocular pressure. It is easier to reduce pressure when you start with high pressure. It's much harder to reduce pressure when you're already starting at low pressure. So low tension glaucoma is very difficult to treat because it's very difficult to go lower than where you are at the baseline. And many of these patients actually are surgical candidates to achieve that target low intraocular pressure.
Thank you. We have another question about what is the link between myopia, glaucoma, and cataracts or cataract surgery?
This is also a wonderful question, and I recently published a paper on this. So as I mentioned, if you have myopia, you also are high risk of developing cataracts. Cataract is basically a cloudiness of your natural lens. The lens in the eye also has different compartments, and it's the nuclear sclerosis part of the cataract, which is higher incidence or higher progression with the coexisting myopia. So as I mentioned to you guys, myopia is a long eye. So when we do cataract surgery, we measure the eye, because when we do the cataract surgery, we take out the cataract and we replace it with an intraocular lens. And that has to be measured preoperatively. In myopic eyes, because these eyes are very long, sometimes these measurements are not accurate. So we have to be very careful as to which formula we're going to use, because we don't want patients to have post-operative surprises. And so that's one thing, preoperatively, to know which formula you're going to use. Number two, intraoperatively, we have to be very careful with our surgical technique, because myopic eyes, once again, are very long eyes. So it's difficult when you're doing cataract surgery. You don't want to put pressure on the posterior capsule of the eye, because there's high risk of complications of cataract surgery in myopic eyes. And then post-operatively, these eyes have higher risk of something called posterior capsule opacity and capsule contraction syndrome. So there are a lot of concerns preoperative, postoperatively, and intraoperatively. I would say when I see these patients who are coming for cataract surgery and they also have myopia, I spend a lot of time with them. I make sure that they understand the potential risks and benefits. One thing I do want to say in terms of the outcomes of cataract surgery, as you all know, cataract surgery is the most commonly performed surgery in the United States. And outcomes are wonderful. We have many, many grateful patients. But in myopic eyes, sometimes the visual outcomes are not as great. Almost 60% of these patients after surgery attain a vision of about 20/40. not better than 20/40. And that is because they have these other issues or layers of the eye which are affected by myopia. And also because of the difficulty with the measurements of the intraocular lens that can give some surprises postoperatively.
Thank you. That was very interesting. And kind of related, what is the relationship between glaucoma, myopia, and macular degeneration?
Wow. So, also very good. Glaucoma, cataracts, and macular degeneration are all age-related common diseases, right? But the challenge we have with myopia is that myopia can also result in myopic macular degeneration. Now, this is a little bit different from age-related macular degeneration, as the name implies, age-related. So most people who have ARMD or age-related macular degeneration, that happens with age. Myopic macular degeneration can take place in a very young individual, a 30-year-old who can lose vision. And it's because the macula is getting thinner and it's getting weaker. And that's why these individuals also need to have their examination done for the eye and get a baseline exam, not just for glaucoma, but also to make sure they're not developing early signs of macular degeneration.
And does continuously wearing corrective lenses for myopia reduce a glaucoma patient's risk of developing macular degeneration or retinal detachment?
No, the corrective wear, whether it's glasses or contact lenses, is helping you to see your environment well. But myopia is a disease, right? And the damage keeps occurring depending on where we are. Remember when I showed you that slide that in children myopia starts and then by age 15 it stabilizes. But then there are some individuals where it never stabilizes. And they go on and develop pathological myopia. So even when their eye growth has stopped, they keep developing, further myopia. So it really depends on your level of myopia, especially if you have high or pathological myopia, then you're more likely to develop all these other consequences.
Thank you. And how do glaucoma and myopia relate to diet? Is there anything one can do in your diet?
Wonderful. So this is a very active area of research. I don't think we have any definitive recommendations, but when this question is asked, I always recommend patients to have a very well-balanced diet, incorporate fruits and vegetables. Multivitamins are good. Special vitamins are good also to protect you from macular degeneration from myopia.
Thank you. We have one question from a person. She's asking about her daughter that has low to moderate myopia. Would getting LASIK surgery now, and would that be helpful to her as she may develop glaucoma in the future? Is there anything she should do now to be proactive at her younger age?
The question was regarding LASIK?
Yes, LASIK surgery.
So first of all, I would not recommend LASIK right away. I think her daughter should get a full eye examination, done by a glaucoma specialist. So all the glaucoma testing can be done. And if LASIK is done for this individual, if she's safe to proceed with this intervention, it will help her to get rid of the glasses or the need for contact lenses, but it's not going to minimize her risk for developing glaucoma down the road. If anything, after refractive surgery, the evaluation of glaucoma becomes more difficult. That's why we need to have those basic baseline test results so we can use that data as we're following these patients over time. So LASIK became very popular, I think, in the 90s, whatever. And now I'm seeing a lot of patients who are coming to me after almost 20 years of refractive surgery. And unfortunately, many of them have early glaucoma, advanced glaucoma, because after refractive surgery, they thought they're fine and they never kept up. They never continued their monitoring. And now they're coming to us and they have glaucoma. So what happens in LASIK is the front window of your eye, the cornea is changed. It's reshaped, it's thinner. So many patients after LASIK, when they go to, say, an optometrist or a non-glaucoma person who may not be very keen about these issues of increased susceptibility for glaucoma in myopic eyes and those after LASIK, if they're just checking the pressure because of the change in the shape of the cornea, the pressure measurement will be low. And they'll say, oh, your pressure is fine, you're okay. Mm-hmm. But you need to pay attention again to the optic nerve. Remember, my main point that I brought up in the beginning of my presentation was that glaucoma is a disease of the optic nerve. The high intraocular pressure is a risk factor, but that's not the total picture. You have to pay attention to the optic nerve.
Thank you. That's very important. And we only have time for about a couple more questions, maybe only one. We have one question here. It says, what, if anything, can be done to slow or reduce the chance of children who have myopia developing glaucoma as an adult, especially for those who have a family history of advanced glaucoma?
So I think the first thing, as I mentioned before, we have to try to control myopia. The incidence, the onset of myopia and progression of myopia, because it's clear that the increase for glaucoma, the risk for glaucoma increases as myopia increases. So if you can somehow control myopia, hopefully you can minimize the risk of glaucoma down the road. But myopia is only one risk factor. Remember, I spoke about other risk factors. Advancing age is a risk factor for glaucoma, and that's something that we cannot avoid. Genetic basis, family history, as I mentioned, certain races. So there's so many risk factors. I think we just have to be aware that there is a connection between myopia and glaucoma. We have to be aware of our own risk factors. We have to get a baseline test, and we need to be monitored regularly. That's the only way you can stay on top of this. Just because you're going to eye doctor doesn't mean that you will not develop glaucoma, because many of these, things happen with advancing age, but at least you will have all the information which will help to follow you more closely.
Very important. Thank you. I think we have time for one more question. And
sure.
Are specific glaucoma drops more effective in combined myopia, primary open angle glaucoma?
So this is interesting. And actually, I'm looking at a study right now for this. Actually, my study looked at the outcomes of SLT in different ranges of myopia. As far as the response to eye drops is concerned, I have not observed any difference. Just like any medication, people have different response rate. So some medications work for you, some don't. And I have seen this all over the space. It's not just myopia, it could be hyperopia. It's just like any other medication for any other disease. Our bodies are so complex, and everyone responds differently to intervention. And same holds true for glaucoma medications as well.
Thank you, Sarvat. Once again, this has been an amazing presentation. You have answered so many of our questions that came in. So thank you so much.
Thank you, Michelle.
Thank you all for making time to be with us today. And don't forget to mark your calendars for June 28th and 29th, 2024. We will be having our 6th Patient Summit in Philadelphia. We will be sharing more information about that event soon. Once again, thank you so much for being here with us today and for joining us in our bold vision of a future free from glaucoma. Because of you, the cure is truly in sight. Until next time, everyone, thank you.